Hello everyone, very glad to meet you here. I'm Liu Xiaodan, a nephrology from the first affiliated hospital of China Medical University. This part, we will talk about the clinical manifestations and treatments of acute kidney injury, AKI. At first, I have a question for you. When we want to distinguish the types of AKI, for example, pre-renal and intrarenal, what information can we get from urine sodium? Do you have some ideas? I will suggest you to think about it based on the pathogenesis. Okay, let's analyze it together. If you didn't think it well, press the stop button for well. In pre-renal AKI, which caused by insufficient circulating blood, the body wants to maintain blood volume as much as possible, so kidney is functioning maximally to retain salt and water. As a result, the urinary sodium is low. While in ATN, acute tubular necrosis, one of the most common types of intrarenal AKI, the tubules lost function and can't reabsorb the salt and water, so the urinary sodium rises. Here shows the answer. Pre-renal AKI, urinary sodium is low, less than 20, while intrarenal AKI, urinary sodium rises more than 40. From the analysis process of this problem, we can see that clinical manifestations should not be memorized from the surface. We should understand why it happened like this, based on the pathogenesis. Now, let's see some typical clinical manifestations. ATN, we mentioned it just now. Remember, dead cells don't work. Allergic interstitial nephritis, AIN, accounts for 10 to 15% of intrinsic renal failure. Fever is present in 80% patients. However, it's very difficult to determine whether the fever is from the underlying illness or from the AIN. Typical clinical course of AKI is divided into 3 stages. First, beginning period. This is the time between the acute injury and the onset of renal failure. Next, maintenance period. Generally, this period lasts 7 to 14 days, but can also be as low as several days or as long as 4 to 6 weeks. Glomerular filtration rate maintained at low levels. Oliguria or anuria may occur in some patients. Finally, come to recovery period. Glomerular filtration rate gradually increased and returned to normal or close to normal range. Patients with oliguria began to appear urine volume increase, then appear polyuria, and then gradually return to normal. When AKI occurs, waste products such as nitrogen, acid, and excess fluid are not removed by the kidneys and builds up in the body. Then, the patients will have the following symptoms, such as nausea, vomiting, swelling of the hands, face, or feet, decreased urinary output, even shortness of breath and enlarged neck veins. Chemicals and electrolytes which are needed for normal body function, such as sodium, potassium, and calcium, will become harmful or sometimes toxic to the body when they reach abnormally high or low levels. Among them, we should be very careful about hypokalemia, which may lead to dysrhythmia and cardiac arrest. Therefore, the patient is monitored for serum potassium levels or symptoms of muscle weakness, numbness. ECG changes may show peaked T waves. Other things, infections is one of the most common complications of AKI because the body's immune system may stop working properly. Almost every system of the body is affected when there is failure of the normal renal regulatory mechanisms. Now, let's talk about the general principles of treatment. The treatment of AKI depends on the causes and may include the three major aspects. Let's talk about it one by one. The first principle: correct the underlying causes of AKI. For pre-renal AKI, optimization of renal perfusion should be made by intravenous fluid or blood product transfusion. For post-renal AKI, prompt relief of urinary tract obstruction is very important. For intrinsic renal AKI, elimination of nephrotoxic agents if possible, and other etiological treatment. According to the second principle, we should pay attention to treat the fluid overload, hypokalemia, acidosis, and uremia. In order to keep fluid balance, we can judge the condition based on daily body weight, blood pressure, the amount of intake and output, or even by measuring central venous pressure. For hypokalemia, we can use diuretics to excrete potassium, use sodium carbonate, or intravenous glucose and insulin to reduce extracellular potassium concentration, and use calcium gluconate to stabilize microcytes. If the hypokalemia is refractory, renal replacement therapy may be needed. For the third principle, here are the indicators for dialysis. The dialysis includes hemodialysis and peritoneal dialysis. Although these treatments may help patients to some extent, remember, an ounce of prevention is worth a pound of cure. Avoid the causes of AKI. Prevention is the ultimate goal. Okay, this is the clinical manifestations and treatments of AKI. Thank you for listening. See you next time.